Greetings, ladies and gentlemen. My name is Victoria Gamba. I am an obstetrician and gynecologist and also an implementation science researcher here in Kenya, and I will be taking you through your module 2 of the female genital schistosomiasis screening, diagnosis, treatment, and the care pathway. Our learning objectives is that by the end of the training, the learners will be able to Objective 1, explain the screening and diagnosis care pathway for FGS. Objective 2, describe the environmental risk assessment to ascertain the risk of schistosomiasis and also FGS, and review the clinical symptoms of FGS. Now, objective number 3, use the WHO Pocket Atlas to be able to recognize female genital schistosomiasis clinical findings on visual examination. Objective 4, explain how female genital schistosomiasis lesions are formed and what happens with treatment. Objective 5, describe the current treatment for FGS, how to administer praziquantel, what are some of the inclusion and exclusion criteria, and what are the potential side effects when you give someone praziquantel. Then objective 6, I understand the care pathway for female genital schistosomiasis. We will be using various resource materials, what has been done before and what is working so far, and hopefully even you as a country will be able to contextualize this to your setup. So some of the content material that we'll be looking at will be the first package material, the WHO Pocket Atlas for FGS that was written in 2015, and then the Countdown FGS Intervention Manual in Liberia, as well as the Countdown Healthcare Worker Training Guide for managing female genital schistosomiasis in primary healthcare. How do we screen for FGS? Remember, FGS, when we talked in the other module, has many symptoms, and many of them do mimic many other STIs. It mimics other just genital tract infections. So how do we get to narrow down to the diagnosis? For screening, we use the whole population, and we try and get our disease of interest by putting some measures or some checklist in place so that we are able to narrow down to who in this particular subset of community is affected by our disease of interest. So what is this risk assessment criteria that we use? The WHO recommends that the diagnosis of FGS can be considered in all women and girls who present with urogenital symptoms and history of contact with fresh water in countries that are endemic for schistosomiasis. So how do you get this history of contact of a water body? You have to do a good clinical history taking, and as well as the exam. So when you're asking in your history, what are you looking for? What are the questions that you're asking? So number 1, you can ask very plainly, do you have any history of contact with freshwater body, such as rivers, streams, or lakes, now or in the past? Remember, we said FGS is a chronic manifestation of schistosoma hematobium infection. So there has to be that past history of contact with an infected or contaminated water body. Now, this kind of contact can come about during your routine work, and mostly in such scenarios where people are fishing, they're washing clothes, they're bathing, they're swimming, they're defecating, they're walking through the water, or farming. Another aspect, you can also ask about their menstrual health hygiene practices. And then what is their source of water that they get? So that can also help you get where, or the possibility of them getting into contact with a contaminated water body. So the next thing is, if one case of FGS is seen, we're going to use this as a satellite because we know the schistosoma hematobium worms lay around almost 200 eggs per day. So that means there's a lot of eggs that can continue with the circulation, and if especially they have daily contact with these water bodies. So that means it's not just one woman or one girl who's affected. You also need to look at the other community members or the family members that might be affected with schistosomiasis. Then we'll look at the risk scoring guide that is factored in from the Countdown Nigeria. And this is a scoring system between 1 to 10. And anyone who scores above 4 is always considered to be at a high risk of having female genital schistosomiasis. And what does a 4 entail? It's mostly what we've talked about is the environmental risk assessment. Okay, and we talked about that history of contact with a water body, whether it's direct or indirect. Okay, and this can come about, as we said in our history taking through, fishing, washing clothes, bathing, walking through the water or crossing the water that might be an infected water source, swimming, or any history of passing urine or stool in such a water body. Then the next step, if it's yes, then they score 4. So that means pretty much everyone is at risk of this disease process. Then 2, if they are unsure. Then you can add other factors, whether they've had any symptoms, and that is in the urine. So painful urination or bloody urine or cloudy urine in the past, which scores, if they have a yes, it's a 2, not sure 1, and if no, 0. As well as the next thing would be to ask if there's anyone in the family. Remember, we are going to use this person as a satellite to tell us whether the rest of the family members of the community could be at risk. So the next step after the self, we go to the family members. Does anyone have any of these symptoms in urine? And then lastly is anybody in the community who they know that is suffering from this. So if the woman or the girl scores 4 and above, it means using the risk assessment, they are likely to have FGS. So how do you proceed from there? We said from there, there's a risk scoring for the risk assessment. Then you also tie it up with your symptoms. Do they have any signs and symptoms of FGS? Okay, and then now from there you will be able to triage and go to the next step. Do they have some of the complications, and what will you do in your visual examination to be able to get to the diagnosis? Okay, so these are some of the complications, and this is just a checklist of the questionnaires that you could ask in addition to your history of environmental risk and the signs and symptoms, as well as now the possibility of having complications due to FGS. So as we know, urogenital schistosomiasis affects the urinary and the genital tract. And when it comes to the urinary tract, because of the granuloma formation and all those fibrosis, it can lead to involuntary passage of urine. And as you can see, the first question on the left is, do you involuntarily pass urine? In other words, or in simpler terms, passing urine when you do not intend to. And we have different forms of incontinence, and we have, for example, stress incontinence. This is where you cannot hold your urine, and any time or any activity such as coughing, jumping, or even walking can actually lead you to leak your urine. Then now we go to all the features that might affect the genital tract and pregnancy by inference. So you could have any of those issues with pregnancy in terms of miscarriages. So whether you've had any pregnancy loss, whether you've had any difficulty getting pregnant, remember there's that history of fibrosis that can affect the tubes, can affect anywhere along the genital tract and even cause ovulation to become an issue, and then that predisposes you to infertility. Then there could be now the actual aspect of having genital lesions, which could be ulcerations or swellings. You would ask about that, and do they have pain or are they bleeding? And most of the time you would have people coming and complaining about postcoital bleeding or postcoital pain or dyspareunia pain during intercourse. So these are some of the things that you can pick and be able to help patients to actually get to a quick diagnosis which is accurate. Then with that, we can also grade the severity, because sometimes it might be difficult to actually know whether it's a moderate, mild symptom or severe. But that said, if there is a symptom, you need to treat. Then once you've tied all that, your environmental risk assessment, your signs and symptoms, your possibility of complication, the next thing is to figure out whether it is within your scope of practice to actually give the patient what they need, or you need to send the patient to the next level of care. And that means referring if you're not able to do the speculum exam, because that is definitely the next step before you even reach the laboratory aspect. So how do we diagnose this? Remember, from screening, we took a bunch of people who are well or who you think might have your disease of interest. You went through them through a series of checklists to be able to see if they have the disease of interest. And finally, you've gotten a few who may be at risk, and now it's time for you to be able to move to the next critical step, which is getting to a diagnosis of FGS. And that means we usually use the WHO Pocket Atlas or guidance in terms of this, where you can use now the next step is visual exam plus or minus a laboratory investigation. So this one is just to show you exactly what the system we've used. So number one, based on the history, we screen all women and girls who present with urogenital symptoms, have a history of contact with freshwater body. And number two, the next step is now going to the visual inspection to characterize the lesions on the cervix and the vagina. And step three, if you have laboratory support, is to be able to do a PCR test from either the cervicovaginal lavage as well as from a swab examination. Okay, we said we avoid biopsy at all cases, okay, because this might increase your risk of acquiring HIV, because remember, with FGS you already have a breakdown in the mucosa. That means whenever you now bring about now biopsy examination, you're furthering the risk of this lady to acquiring HIV and AIDS. So a brief overview about the Pocket Atlas. It was actually brought out or published in order to just increase the index of suspicion among health workers who was shown to have very low diagnosis, or I usually misdiagnose FGS. And so part of the reason was to be able to help them to be able to have a high index of suspicion, especially in areas that FGS remain highly prevalent. So in essence, a high index of suspicion allows the diagnosis of FGS preoperatively and avoids unnecessary radical surgery, as well as misdiagnosis of STIs. So accurate diagnosis of FGS requires a specialist, and this is mainly just because of more training, more exposure. It's more about experience. The more you see, the more you're able to be comfortable to be able to diagnose this and to also give the women the service that they deserve. So what are the standard operating procedures for speculum exam? and the FGS flowchart. We will be using this as from the countdown package, and the main thing is, as a clinician or as a health worker, you need to be able to do the clinical assessment. Remember, if there are no symptoms or FGS, then you need to refer the patient for other investigations or assess for other possible issues. Then the next thing would be from the yellow box for the clinical assessment. What are their presence of FGS symptoms? If they are there, then the next thing is you've asked about remember you've done the environmental risk assessment. You're now doing the clinical assessment for presence of FGS lesions and complications. Then the next thing you need to do is a visual examination, and this one you do it through using a speculum. So you always have to prepare your patient, and this means you have to prepare your patient, your equipment, and she has to understand what the procedure entails. Will it be painful? Allay the anxiety that might be associated with this procedure. Then from there, you must have a chaperone. Remember, you're going to look at the genital tract, and you must have someone with you in the room. And the next thing is the pre-speculum examination. You position and engage with the patient. The patient needs to be in lithotomy position, and you ensure you ensure the procedure is following the proper aseptic techniques. Then during the speculum exam, what are you going to do? It's a stepwise examination of the external and the internal genital tract of what you can see. So from the outside, you will come into contact with the introiters. So you need to tell us whether the external genitalia is normal or not, looking at the vulva, which contains the labia majora, the labia minora, and the clitoris. Then after you part them, you should be able now to go to the next level, to be able to assess the vagina. Remember, the vagina has 4 walls, the anterior and posterior, and the 2 lateral walls, as well as all the 4 fornices, okay? The anterior, posterior fornices, and the lateral fornices. Then finally, you will be able to assess the cervix at that point, okay? But what are we looking at as we are doing all this step-by-step examination of the genital tract? You want to look for presence or absence of any of the 3 most pathognomonic features of female genital schistosomiasis. And these ones include the sandy grainy patches, the homogeneous yellow patches, and the rubbery papules. Abnormal blood vessels are not specific for FGS, but they will be there because it's an inflammatory process, and it's very common in anything that causes inflammation, and especially in FGS, as well as HPV or cervical cancer lesions. Then the next thing is, are they there or not? If they are, you need to treat with praziquantel. And if you're in a capacity or you have a lab with a capacity to test for more, to just tell us about the genital assessment, to give us a laboratory assessment of it, then you can send the lady to the lab to be able to either do the PCR antigen tests, DNA PCR, the DNA PCR test for schistosoma hematobium, or sometimes by proxy you can just check the urine to be able to just know or quantify whether there's also urinary schistosomiasis. But that said, presence of any of these lesions is enough for you to actually give treatment for treatment with praziquantel. But then if there are no other signs of FGS, then it means it is highly likely that there are other disease pathologies, so you need to collect other samples so that they can be investigated accordingly. Okay. So this is what you need for a pelvic exam. you can see, of course, you need the patient to be well prepared, has emptied the bladder, and you're able to now have a chaperone there, and you have a good source of light, and the patient is in lithotomy position. And we talked about the stepwise inspection of the vulva, and then you insert the speculum to obtain good views of the cervix, vagina, and the fornices. Okay, if available, position the colposcope or camera and start with low magnification. Then manipulate the speculum to visualize all the fornices and vaginal walls. Then once you have that, remember you are looking for the 3 distinct features, as well as you need to compare it with the WHO Pocket Atlas. So what does a normal cervix look like when you're doing this exam? You can see a nice clear picture of the cervix. I hope the arrow is showing. So from the outset, you can see a very nice homogeneous pink surface. It looks like a very nice color. And then on the inside, you can see a nice slit shape, and it's more red compared to the other structures. So that shows the interior part, which is the end of cervix that connected to the external cervical os. And then the outside pink is the ectocervix, which is mostly lined by the stratified squamous epithelium. So the red bit is mostly lined also by stratified squamous simple columnar cells. Okay, so that's the difference, and that's always our area of interest, especially when you're doing the cervical cancer screening, because it helps you to show the area where the transformation zone is, and that is where most of the lesions for cervical cancer tend to attack. So what are patches? Remember we talked about the 3 specific things. So a patch for FGS rather. So a patch is a flat non-palpable lesion more than 10 millimeters, often seen as an area of color change. We've talked about the 2 types that we might see with FGS, the homogeneous, which is just confluent yellow patch, as well as the sandy grainy rice appearance of patches. So here are some of the examples. I hope using this graph, this side, you can be able to see the specks of sand, or if it's rice green appearance that you're seeing. And this is actually how it looks like in the cervix. Okay, and then also now when you're able to look at this is exactly, you can see the many speckled appearance for the sandy patches, as well as many prominent blood vessels. These are the branch type and or the circular types, but as I told you, the most characteristic is the 3 features that we are looking for: the sandy grainy patches, as well as the homogeneous yellow patch. Remember to look for this more when you're looking at the WHO Pocket Atlas for FGS. You will be able to see all this. Then you can also look at the yellow sandy patches around here. Yes, you can see quite a lot, and also I'm sure you can now be able to see the abnormal blood vessel. Okay. Then of course this one is just showing you the many abnormal blood vessels. These ones are even now starting to branch and causing that mosaic like appearance, as well as now you can see many abnormal blood vessels in the same. So the third thing we've talked about is the papules. They are well circumscribed, solid elevation of the skin or mucosa, and they tend to appear whitish and pustular, but rarely contain any fluid, and they're usually firm in appearance. So how do they look? When you look at these 2 slides, this one has just mapped out how it looks like, just an elevation of the mucosa. And this one now gives you the very clear characteristic of how it looks like. So you can see the elevation, the whitish bulge, and they tend to be firm and they do not have any fluid. Okay, you can see the same here and here and here, the rubbery papules, and then here you can see some blood vessel. It's a circular blood vessel with this contact bleeding that was there. Okay. Now, what are some of the differential features whenever you have any of these symptoms of FGS, the non-specific ones or the lesions themselves? So you can have Nabothean cysts, you can have cervical ulcerations, cervicitis, STIs, other causes of the vulvovaginal discharges, and cervical cancer. So how do you differentiate them? It would be good for you to be able to just see what they are, how they present, so that you're able to see how best to differentiate from what you know. So when we look at this, on the left hand side at around 11 o'clock, this is still the cervix. You can see the nice red appearance of your endocervix and the nice pink appearance of your ectocervix, and outwardly you can be able to see a nice circular structure, very it has a nice circumference, very nice. You can clearly delineate it. Remember, as we were looking at the FGS lesions, they are very irregular, even if it's the homogeneous patch, but this is well circumscribed. And you can see it looks almost like a satellite node. That's how we call it. So they may be confused with rubbery papules, but you can see Nabothean cysts are often bigger, and if so, they also do not protrude from the surface. Remember, Nabothean cyst just shows you the demarcation of the internal endocervix and the ectocervix. So where some of the mucus plug was trapped, so it shows you where that demarcation is. Then we have other STIs that can cause inflammation of the cervix, but as you can see, you neither see none of the other yellow sandy grainy patches or all that. The only thing you see is purulent cervical discharge as well as inflammation of the cervix. Then you can see sometimes when they occur in tandem, I'm hoping you're able to now see the yellow grainy, sandy grainy patches around here, as well as areas of punctate hemorrhage. And this is very characteristic, and it's giving the clear picture of a strawberry cervix that's very common whenever you have Trichomonas vaginalis infection. So this patient actually had a co-infection of both STIs as well as Trichomonas vaginalis. So the next one is based on after application of VIA. You can still see our endocervix should be down here, which is a bit red compared to the rest, but they've applied acetic acid that has caused all this acetal whitening at this transformation zone. And of course, following now histological exam, you're able to get the CIN classification, okay? But the thing is to be able to differentiate this, because the schistosoma lesions are not necessarily, they're not restricted or confined to the transformation zone. And as we say, they can attack anywhere along the reproductive tract, from the vagina to the cervix to the uterus, where we are not able to see, to the fallopian tubes, to the even ovaries, okay? So mostly one of the differentiating features also is they do not take up this acetal whitening stain, because of course we know the difference why HPV infected cells do take up this acetic acid from the protein coagulation, or because of the increased nucleocytoplasmic ratio that actually leads to that dehydration, and the nucleus is more apparent and it's more reflecting of the light. So lastly, we have this that actually shows you some of a lesion that looks malignant, but from histology and biopsy exam, it was actually schistosomiasis. Then you can see the flat condylomas that are caused by HPV DNA. Okay. Then you can still see some of the sandy grainy appearances, as well as the areas of petechial hemorrhages and the abnormal blood vessels. So our key learning points out of this module is, when you're doing the speculum exam, there are three things you must have in mind that you want to check when you're looking at the lower genital tract. And these are the sandy grainy patches, or the homogeneous yellow patch, or the rubbery papules. And to diagnose this, you need to look at all the mucosal surfaces with a good non-LED light source. And then after that, you will either use the laboratory arm to help you to strengthen your diagnosis. But remember, presence of these lesions is important and is enough for you to start the treatment for FGS. So what is this treatment for FGS? We've talked about praziquantel throughout, and this is based on your we have different criteria for indications of treatment. And number one, we've talked about the environmental risk and the signs and symptoms and the presence of the lesions on speculum exam, number two. And then number three, if someone has missed a previous drug administration and they fall under the same area where you found people to be at risk of that. Then the eligibility for treatment with FGS with praziquantel, as you can see, it's basically for everyone. The only exclusion would be that if women are pregnant and in their first trimester and you're not sure, it's always good to check and confirm with your country specific guidelines on when to treat. And for sure, when we look at the nursing mothers, we've seen that the amount that is released in milk is very minimal, and most of the times we allow you to actually give to breastfeed because there have been no studies to show any adverse events. But if you're in doubt, sometimes you can allow at least 24 hours before you give, you breastfeed. Then people who've received praziquantel over the last six months, and if you're on any other medication that can interact with praziquantel, such as rifampicin. And rifampicin has major interaction with praziquantel, and it's often a drug inducer, so an enzyme inducer. So that means it ends up reducing completely the levels of praziquantel. So you may not get the levels of praziquantel that you need in your blood circulation to be able to treat. And those who are unwell, you do not want to make them to be more unwell. You can defer the treatment to a later date, but you have to document that somewhere and ensure you follow them up. So FGS treatment, we've talked about praziquantel at 40 milligram per kg as a single dose, and this treatment is usually to kill the adult worm and prevent development of new lesions. And treatment can improve reproductive health, and so it can improve reproductive health and diminish FGS symptoms. If one FGS case is seen, there are probably many more in the same area. So all those who use the same water points are definitely going to be at risk, and plans need to be made to do chemo prophylaxis of this. And then in endemic areas, regular treatment of young girls is necessary. So we do have height-based dosing for MDAs most of the time. However, in very rare instances when the weight scales are not available, you may need to use this. However, for treatment of FGS, a weight-based approach is the most preferred and most accurate. So what are some of the questions to ask the clientele before taking the medication is whether they've eaten, are they currently sick? Remember, this was a negating factor, whether or not to continue the medication, and if they're currently on other medications that might interact with praziquantel. And for instance, we talked about the major interaction we have is with the rifampicin, which is a major drug inducer. Then do they have any history of seizures? Because most of the time intake of praziquantel can actually induce a seizure in someone who has this history of epilepsy, and also in someone who has some of these anti-epileptic drugs, because they tend to increase the level of praziquantel. So you need to be very careful about that. And then if they're pregnant, we know that the WHO has allowed us to give praziquantel in all trimesters. As a country, you can adopt a country-specific adaptation or guidelines for this. The only thing that has always been of concern is within the first trimester. Then when we look at the side effects, as with any drug, you can have the normal GIT reaction from abdominal pain, nausea, vomiting, diarrhea, or malaise, and that's less than 2 hours. So anything that lasts less than 2 hours is considered to be minor. Anything that persists beyond that then is an issue, and the patient has to come back to the facility. So how do you minimize some of this? We know praziquantel is better absorbed when you take with food, and some of these GI side effects are less when it's also taken with food. Then there are these allergic reactions. The same way, if they're less than 2 hours, then it's okay. But if they go beyond that, you have to intervene, and you can even give them some antihistamine as well as some anti-inflammatory medications, as well as ensure that they are referred to the facility as soon as possible. And the worst case is when they do have seizures, shock, or unconsciousness, then immediate referral to the health facility is advised. They can also have abdominal pain, which we've talked about, and these are the various ways to manage. So the way forward for those in the exclusion criteria, we said we're going to document and be able to give them a proper follow-up date to come back. And some of the drug interactions we have listed here is for you to be able to see. We can give you a direct website or link that actually shows you can enter the drug you're giving to be able to see whether or not it interacts. And finally, the FGS care pathway for you in your facility. So you will look at this, and you should be able to know whether or not you're in a position to give all this, because as we said, the first thing is the patient will come with gynecological issues. The next thing for you is to collect a history and look at what are the specific signs and symptoms that they have. By administering either a questionnaire, or you can ask the way you normally conduct your history, and then also do an environmental risk assessment. So of course, if they score above a 4, we are going right like this. Then the next thing is you have to suspect FGS. You can do the severity score and do, if you're able to do or refer to for speculum exam, the better, if you're in a clinical setting. If you're not, then this is still a potential subject who might need a presumptive, we can call that a probable diagnosis of FGS. And if you're in the community level, you may give, and you're allowed to give praziquantel, then you may give. However, if you're not, then the next thing would be refer to a facility where they're able to do the next step and look for the lesions and even do a laboratory exam. Then at the same time be able to treat. So I will not dwell so much into this pathway, because I want you as a country to actually come up with your own context. How and where do you meet this patient? So that when we go to the next slide, it's very clear that this is exactly what you're going to do as this kind of cadre of healthcare practitioner in this country, so that we are able to adapt this for you, something that works also in your setup. So I will let you read this, and as we're doing the discussion in the next webinar, then we can be able to really tease out what is your role, because you have to be very clear on what your role is, so that you either escalate or refer to the next level and the patient gets actually what they need. Okay, then I would like to take a special thank you for the various slides, or the people who took down their time to actually write a lot of literature that is now guiding us in these modules, from the LVCT Health, the Countdown Nigeria and Liberia, and the WHO Pocket Atlas, and to our many implementers in the FAST package. Thank you for all this. And we hope we are going to have a successful integration process, and we are looking forward to the next step. Thank you very much. I'll hand over this to our chair of the session. Thank you.